tonight's faculty. Our first speaker, I have the pleasure to present Dr. Patrick Yachimski from the Vanderbilt University Medical Center. And Dr. Yachimski comes to us as a faculty in medicine. He's been there since 2009. He finished his training in undergrad at Harvard School of Medicine, and he currently serves as Associate Professor of Medicine and the Director of the Pancreatobiliary Endoscopy. He will talk to us about atypical presentations with exocrine pancreatic insufficiency. Dr. Yachimski.
Great, thank you so much for the kind introduction, and I'm delighted to be here. I hope everyone's in a comfortable place. I'm going to try to share my screen here, and what I'd like to do is spend the next 15-20 minutes on this topic, atypical manifestations of exocrine pancreas insufficiency. Let's see if I can get my, let's see. Sorry. Here we go. Can everyone see that? Terrific. So there may be folks on the conference who are far more expert in this area than I, but I want to at least give you my practical approach to thinking about this problem. Just to make sure that we're all on the same page, these are a few abbreviations that you'll be seeing in my slides listed here. We are all trained in medical school, nursing school, et cetera, to really recognize steatorrhea, oily, greasy, foul-smelling stools that are hard to flush as really the cardinal hallmark symptom of exocrine pancreas insufficiency. But it's important to keep in mind that development of steatorrhea really requires massive impairment and elimination of normal glandular exocrine function. By some estimates, 80 to 90% of the exocrine pancreas needs to be non-functional before steatorrhea will develop. So if that is our index for thinking about whether EPI may be present in patients, that's only the tip of the iceberg, and we're missing a large population with more subtle symptoms, perhaps earlier stage disease. These symptoms could include weight loss in the setting of malabsorption, malnutrition, or simply abdominal pain and abdominal bloating. And I want to remind everyone that the systemic consequences of malabsorption due to pancreatic insufficiency can be profound. This is a study that came out towards the end of my training that remains an important study, looking at the risks of fracture in CP chronic pancreatitis patients compared to Crohn's disease patients, folks that we think are at high risk for fracture due to chronic glucocorticoid exposure, and controls. And you can really see that at all locations here, vertebral, hip, wrist, chronic pancreatitis patients, as a consequence of their exocrine pancreas insufficiency and malabsorption, are at really profoundly increased risk. And if there's an opportunity to intervene and identify and recognize these patients early on, we can potentially prevent a lot of morbidity in at least just this one feature of the musculoskeletal system. It is also important to recognize and to take a step back, think about pancreas physiology and pathophysiology, that there can be derangements that have nothing to do with impaired function of acinar cells that can result in pancreas insufficiency. Derangements in hormonal signaling, derangements in the duodenal mucosa that can affect triggers to neurohormonal signaling. So for instance, folks who may be at risk for pancreas insufficiency include not just folks with chronic pancreatitis that we would classically recognize, but patients with pancreatic duct obstruction. And generally, my oncology colleagues are quite good at having their patients with pancreas adenocarcinoma on pancreatic enzyme supplementation. Patients on chronic somatostatin analogs to treat, for instance, carcinoid syndrome due to the interruption of hormonal stimulus to pancreas secretion. Patients with infiltrative disorders such as hemochromatosis, patients with hypersecretory, acid hypersecretory states such as Zollinger-Ellison syndrome, in which the overabundance of acid effectively neutralizes the pancreatic enzymes and does not allow for the normal duodenal pH milieu necessary for activation of the enzymes. And then celiac disease, in which folks with mucosal denudation or derangement of the duodenum don't have the triggers to stimulate neurohormonal signaling to trigger pancreatic secretion. Other groups of folks who we need to think of are folks who've had surgery. I think we're all quite familiar with the concept that folks who have had pancreas resections for either benign or malignant pancreatic disease can be left with impaired residual glandular exocrine function. This is much more likely to be prevalent following a pancreaticoduodenectomy as opposed to a left pancreatectomy. But it's important to recognize there are also a range of other foregut surgeries, including esophagectomy, gastrectomies, and small bowel resections that have been associated with pancreatic insufficiency, whether that's due to, again, changes in neurohormonal signaling, whether it's due to poor mixing, it may be multifactorial, but these are patients, and if you're seeing these folks in clinic after foregut surgery and they have unexplained gastrointestinal symptoms, you might want to think about whether exocrine pancreas insufficiency could be at play. Now, when we consider this diagnosis, what are the tests we have at our disposal? Classically, it would be either qualitative or quantitative fecal fat testing. The classic test would be a 72-hour fecal fat collection to quantify the fat content of the stool. I and many of my colleagues, I think, have found that this is one of the best ways to guarantee a patient never comes back to your practice because it's such a cumbersome test, it's unwieldy, patients don't complete it, and they don't come back to see you. So you miss the opportunity to establish a diagnosis, establish rapport with the patient, and to initiate treatment. What many of us have since turned to is spot fecal elastase testing because it can be easily obtained and assayed in a single stool specimen. Some centers, not widely available, some centers are using secretin-enhanced pancreatic function testing. This is typically coupled in many centers with an endoscopic ultrasound examination in which the pancreas can be assessed for structural disease, and following administration of intravenous secretin, duodenal secretions are collected at 15-minute intervals for 45 minutes to an hour, measuring bicarbonate peak concentrations. Now, remember, bicarbonate is really from the ductal cells. So this is not a direct measure of acinar cell function, but is a good surrogate. And emerging into research and clinical use are labeled breath tests. I do not have personal experience with this, but certainly if this is something that would be available as office-based point of care testing, the way we use, for instance, H. pylori breath tests, this would facilitate ease of testing and diagnosis for patients in whom we have suspicion. Again, with regards to the fecal elastase test, which is, I think, one of the most widely used assays at the moment, abnormal is defined as below 200 micrograms per gram of stool, with really severe or profound deficiency defined as less than 50. The sensitivity for moderate to severe exocrine pancreas insufficiency for this assay approaches 100%. However, you should be aware that there may be false positives if it's a very watery, dilute stool specimen, particularly in the context of secretory type diarrheas, one might get a false positive. So again, if we take a step back and try to think about which patients we're seeing in practice, should we be worried about exocrine pancreas insufficiency, even absent a prior known diagnosis of pancreas disease? Some of these symptoms, pain, bloating, very subtle or overlap with a lot of what we're seeing in our general gastroenterology practices. So the question can be asked and has been asked in a general GI adult population of patients presenting with symptoms that might be consistent with functional disease or irritable bowel syndrome, does it make sense to widely screen and canvass for exocrine pancreas insufficiency? In this study, 218 patients who presented with IBS type symptoms. And if you look down to the bottom of the chart, the prevalence of exocrine pancreas insufficiency diagnosed in this cohort by fecal elastase assay was about 3% of patients. So that's perhaps not a small number, and you could decide in your practice whether it would make sense to screen patients on this basis. I would say that, certainly we routinely screen patients presenting with IBS type symptoms for things like celiac disease in our practices, and the prevalence of that might not be much higher than what we're seeing here for exocrine pancreas insufficiency. I would say that if you are going to hone down on one group of patients in your practice to try and identify, it would be patients who are smokers or have a cigarette smoking history. It has been increasingly recognized, and clinicians and patients are becoming aware of this, that smoking is a major modifiable risk factor for acute pancreatitis, for chronic pancreatitis, and for pancreas adenocarcinoma. And there's clear data demonstrating that smoking correlates with pancreatic fibrosis, pancreatic inflammation, and fibrosis. This was a simple but elegant and I think important study done by Field Willingham and his colleagues at Emory, where they took just a general primary care population. They excluded patients with known pancreatic disease or known risk factors of pancreatic disease, and they simply gave everyone a fecal elastase assay. And what they found, compared to controls, the prevalence of pancreatic insufficiency in smokers was 18%. And the prevalence of severe exocrine pancreas insufficiency in smokers, again, without any known pancreatic disease, was 10%. This is a sizable population at risk that I think could justifiably be screened in a GI practice, certainly, if not a primary care practice for exocrine pancreas insufficiency. A couple of other groups really to think about, on the horizon in our clinical and research worlds. It's being increasingly recognized that type 1 diabetes is really not limited to endocrine pancreas injury, that there is probably also some injury to the exocrine pancreas. And that can be mediated by T cell destruction of exocrine tissue, fibrosis, inflammatory cellular infiltrate, vascular injury, and ultimately fatty infiltration. And indeed, if one looks at exocrine pancreas insufficiency as measured by fecal elastase assays in patients with either new onset or longstanding diabetes compared to controls, there really does appear to be, at least by this assay, fecal elastase, some drop off in exocrine pancreas function, which correlates to some degree with the duration of diabetes in the patient. Now, that being said, it's not clear that in most of these patients, the impairment of exocrine function reaches a level that would be clinically significant. And I would also point out that in folks with type 1 diabetes, there are a number of other factors that can contribute to gastrointestinal symptoms, including gastrointestinal motility in the setting of autonomic neuropathy, small intestinal bacterial overgrowth, and a fairly significant prevalence of celiac disease in patients with autoimmune disorders such as type 1 diabetes. So I would at least run through this list and go through these factors before thinking about exocrine pancreas insufficiency as an explanation for GI symptoms in a patient with type 1 diabetes. Another population that really is blossoming into epidemic is our patients with non-alcoholic fatty liver disease. And again, it can be demonstrated in folks with non-alcoholic fatty liver disease compared with controls. If you look at the chart on the right here, there can be impaired exocrine pancreas function as measured by fecal elastase assays. Perhaps not to the degree that would manifest as clinically significant pancreas insufficiency, but certainly something to keep an eye on as we learn more about the NAFLD population and the extrahepatic digestive manifestations of this disease. And from the same study, and I know Dr. Trout is going to talk a little bit about imaging and chronic pancreatitis, it appears this is the proton density fat fraction. This is due to fatty infiltration of the pancreas, just like fatty infiltration of the liver. One message that I think is important to get out there is that all of us who see patients with pancreas disease can perhaps do a better job in diagnosis and treating these patients. So this is a study, Chris Forsmark was the lead author several years ago, where they looked at patients with both chronic pancreatitis and pancreatic cancer. And you can see the very, very small percentage of patients who had any testing for exocrine pancreas insufficiency, percentage of patients who filled a prescription for pancreatic enzyme replacement therapy, and percentage of patients who are on adequate dose of pancreatic enzyme replacement therapy. Now, that being said, this is not to lay all the blame at the foot of clinicians, because let's be honest, we know there are other barriers to use of these medications, including what can be sometimes cost prohibitive medications, even for patients with health insurance. These can be expensive medications, and that certainly can be a barrier in some practices for some patients. I think the other thing to recognize is that, and this is from a Cochrane database review, a lot of what we know, and our moderator can speak to some degree, a lot of what we think we know about pancreatic enzyme replacement therapy is extrapolated from the cystic fibrosis literature in pediatric populations. And there is not a high degree of level 1 evidence to support the long-term benefits and risks, or actually what the exact correct dosages should be for patients requiring pancreatic enzyme replacement therapy. What the general rule of thumb is that, you know, the adequate dose of lipase for a meal, it would be 75,000 units of lipase. So, you know, if I see a patient who has known exocrine pancreas insufficiency and comes to see me with persistent symptoms, and they're on a dose of 6,000 units of pancreolipase per meal, that's a homeopathic dose. And there's a lot of room for dose escalation on that patient. A lot of centers now are using weight-based dosing algorithms that's automated into the electronic medical record with prescription ordering, and that can be helpful as well. The last slide I would show, and this was borrowed from my former colleague, Doug Seidner, who was with us at Vanderbilt for many years and now has returned to the Cleveland Clinic, is just remember, when you're dealing with malnutrition in patients with chronic pancreatitis, there's more going on than just the exocrine pancreas insufficiency. It's not just putting them on pancreolipase and saying, all right, problem solved. These patients can have poor oral intake due to pain, and they need pain treatment. I know Dr. Singh is going to talk about this in this webinar in a few weeks. They can have small intestinal bacterial overgrowth due to chronic dysmotility, perhaps in the setting of opioid analgesics use, or the setting of chronic proton pump inhibitor use. So there's a global assessment and management that needs to occur for these patients beyond just treatment of the EPI. So in summary, and I hope I've left some time for questions, remember, steatorrhea is only going to be seen in folks with advanced exocrine pancreas insufficiency. And given that symptoms of earlier or more subtle EPI may overlap with what we also see in many other GI disorders in the adult population, you really need to be honed in and have the appropriate index of suspicion to make this diagnosis in at-risk patients. I think we can look forward to the future and learning a lot more about how much we need to think about and worry about EPI in populations like type 1 diabetes and non-alcoholic fatty liver disease. So thanks for your attention, and I hope I'll be able to answer any questions that you have.
Yeah, thank you, Patrick. That was a very nice summary and review. And I do agree with you that we have learned a lot from the CF population when we manage patients with other exocrine pancreatic insufficiency related diseases, mainly for chronic pancreatitis. And we do in pediatrics see other congenital syndromes resulting in EPI other than CF. You know, some of them are Schwachman-Diamond or Pearson-Marrow, and some are actually still not categorized to belong to any of these entities, so need more genetic testing, but definitely they have EPI. So I wanted to ask you a question about, and you alluded to it, that once you know, benefit of the treatment, once an EPI diagnosis is established, I guess my question is twofold, and for the practitioners here, what test would you recommend you start with when you suspect EPI? And how do you go in terms of the escalations in terms of your workup?
I guess I would answer that in two ways. You know, one is just simply establishing the diagnosis of EPI, usually with a fecal elastase assay and starting enzyme replacement therapy and counseling the patients on the importance of maintaining that, even if they're not having steatorrhea, as many of them won't. But the other thing that becomes very important, you know, in my population of adult patients, many of whom I'm seeing in their 5th, 6th, 7th decade with new unexplained, they never knew they had pancreatic disease, and now they have idiopathic exocrine pancreas insufficiency, if not chronic pancreatitis. So there's a parallel diagnostic investigation to determine what, if anything, may have been the identifiable precipitant, whether it's smoking, whether it's genetics, because of course folks are interested in knowing what, if anything, they can do to prevent you know, accumulating further pancreas injury. And sometimes that's as simple as telling a smoker to stop smoking. Other times it's more challenging. You know, we also, again, if you're seeing an older patient presenting with new unexplained EPI, new unexplained pancreatic disease, you do always need to worry about occult pancreatic neoplasm. and make sure the patient has high quality pancreatic imaging, cross-sectional imaging to make sure that you're not missing that.
Yeah, but it sounds like you start with a screening test, which is the fecal elastase, one of the most common, in use. And I totally agree with you that I don't remember when was the last time I've seen a 72-hour fecal fat collection being ordered, because it's very cumbersome and it cannot be even done right if the patient doesn't eat the right amount of fat. And you're right, they probably would not do it and not come back to you. It's hard enough to let them drop a fecal elastase sample. Now, my other part of the question, once an EPI diagnosis is established, we've seen patients that are dosed, at the dosage that you recommended. In pediatrics, we follow like a per weight based dosage, so 500 to 2500 international unit of lipase per weight for the body weight, kilogram, and then we base that for each meal. Once you really are on a good dose and the patient still has steatorrhea, what do you do in these cases? Can you tell us some of the tricks by which you can overcome that?
Yeah, it's a good question. I'll be curious to hear your thoughts as well. The first thing that I think of is whether, even aside from Zollinger-Ellison syndrome, whether there's an acid hypersecretory state. Mike Vasey and I published a study several years ago demonstrating among patients with gastroesophageal reflux disease, which again is pretty prevalent in the adult population, even on once daily proton pump inhibitor therapy, 20% of patients will still have pathologic levels of acid suppression. So an easy thing to do is to put them on a PPI, even though most of these enzymes these days are enteric coated and should withstand gastric acid, put them on a PPI and see whether that helps. Thoughts on that?
Yeah, I do that. You're right. I really, once you reviewed the dosing, and if it's adequate, I really would recommend to do a PPI and see if that helps. Another thing that I try doing is to have them split the dose. So take the first, half of it with the first bite of food, wait, 5 to 10 minutes into the meal, take the second half of the dose so that there's more constant release rather than one bolus. And then, treating if there's any element of small bowel bacteria overgrowth and things like that. But those are very tricky situations.
I think the other thing that's critical is, as I mentioned, having a good rapport with the patient, so you know that you and the patient could be honest with one another. Because look, if someone has a prescription for 24,000 units of pancreolipase, take 3 with each meal, 1 with each snack. If they're doing that right, that's 11 pills a day. That's hard for even a motivated patient to do. And if they're not doing it, if I don't have a good rapport with them, they may be unwilling to tell me or not comfortable telling me. And if they're not taking the medication as prescribed, that's a good reason why it's not working. So you need to be able to have those discussions with patients.
Yeah, and it really brings one of the audience questions. Sylvia here asks, in the absence of causes of EPI and others you show, how do you approach a fecal elastase test that we call borderline? So between 100 and 200, what is your approach for that value?
Yeah, I think, I might repeat it, and see if it's reproducible, especially if I don't have information from the lab on whether it was a dilute sample. I would make sure I've thoroughly considered other possibly etiologies for the patient's current symptoms. Again, where I'm dealing with sometimes older adult patients who, may be at risk for structural pancreatic disease. I'm often coupling it with some form of imaging, often an endoscopic ultrasound in my practice, to see whether there's compelling imaging evidence of chronic pancreatitis to be supportive of that diagnosis, knowing that, again, EPI can exist without established, glandular evidence of chronic pancreatitis and other pathophysiologic states.
Yeah, and I would agree with that. Repeating it would be the first way. And usually that's when I go in also when there's suspicion, because the patient is not going to be compliant. I would go to a direct pancreatic function testing. And that's where, the secretin function testing that Andrew will talk about, or the endoscopic pancreatic function testing, or EUS direct pancreatic function testing, one of those where you directly measure the function would be helpful. Well, there's many more questions and it's very active, but I think for the sake of time, we're going to take one last one from Dr. Gupta. How is other people's experience with Relisorb in tube-fed patients with EPI? Have you had experience with Relisorb as the lipase cartridge?
I have not. I'd be curious to hear if others had.
So we've used Relisorb in patients who are on combination of oral plus tube feeds. I have not used Relisorb in patients who are solely on tube feeds because Relisorb is the lipase only formulation. So the other pancreatic enzymes, not to advocate for any company or the other, scientifically, if you use any other formulation of pancreatic enzymes, you have your lipases, proteases, amylases, propeptidases, everything. So I worry in a growing child if their sole mode of nutrition is tube feeding only to just rely on Relisorb. However, we need more studies to show that it allows carbohydrates and protein absorption adequately, so a room to study it. So if I have a patient who's on a combination, and there are studies on that, like let's say CF patients, they use tube feeds at night, and they have to be continuous, by the way. Relisorb is a cartridge that you run and Y in with the feeds, and it runs continuous, and it's about 500 units. I think that's about the measure of, no, it's one cartridge is enough for 500 ml of formula. So you need to double it up if you're using 1,000 of the regular formula of 1.0 calories. So it has some formulations because it's on the lipase, but it has to be continuous feeds. The patient is usually on a combination of oral and enteral feeds. It has been associated to improve symptoms in terms of bloating, diarrhea, steatorrhea, and weight gain because it does decrease the osmotic load. All right, so this was very helpful. Thank you, Patrick. And maybe stay tuned so that if we can answer some of the questions in the chat, you and I, we can tackle them together. So thank you very much. I have the pleasure to introduce the next speaker of this evening. He's actually a friend and a colleague also, Dr. Andrew Trout, who will speak to us about